Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
So our topic today is pulse ox screening for newborns. Is it making a difference? My guest is Dr. Stephen Kaine. He is the director of the Cardiovascular Laboratory and associate director of the Ward Family Heart Center. He's also an associate professor of pediatrics with the University of Missouri, Kansas City School of Medicine. Dr. Kaine, welcome to the show.
Thanks very much. It's good to be here.
So we're going to talk about what impact the pulse ox screening has done since it's been implemented. But first, let's just get some background information. What percent of infant deaths from defects are attributed to congenital heart defects?
Well, in the first year of life, deaths related to congenital heart disease account for about 30% of deaths related to birth defects. Congenital heart disease is actually a very common form of birth defect, affecting about 1% of all newborns.
Right. And so when you look at the pulse oximetry screening, what percent of newborns prior to doing this as screening in the hospital were sent home with a critical congenital heart defect? Do we have that kind of data?
We do. Because congenital heart disease is fairly common, as I mentioned, with about 1% of newborns affected, about 50,000 babies a year. We had lots of information prior to 2010 about how many babies went home. About 10,000 babies of those 50,000 with birth defects had what we refer to as critical congenital heart disease. And of that 10,000, as many as 2,500 to 3,000 babies per year were being discharged from the newborn hospital without their defects being diagnosed.
And what is that? So when you look at a baby who's being sent home with a critical congenital heart defect, what's the outcome? When that happens and we don't catch it, what's the common outcome for that child?
Well, the outcomes are very much different in those children compared to children who have their diagnoses made in a timely fashion. The most significant issue is the risk of returning to the hospital in a very ill state, which happens very commonly in those babies who are discharged early without the defects being known. And that affects the outcome of their surgical intervention or their treatment that they need. Babies in this state typically go home undiagnosed with some protection. The fetal circulatory structures allow a child to actually do well for a few days. But once the ductus arteriosus closes, the child becomes quite ill. And as I mentioned, the outcomes are significantly worse. Specifically, a study done in Sweden that really highlighted this impact showed a survival during the first year of life for children who went home without their defects diagnosed, only about 10% compared to those who did have the diagnosis made timely.
And this is exactly why, wanting to catch those defects before they leave the hospital was something that became very important to physicians like yourself, to Children's Hospital. And this is where the pulse ox screening was initiated, correct? So tell us a little bit about how Children's Mercy implemented this screening in newborns.
Well, the newborn screening was recommended by the Secretary of Health and Human Services, Sebelius, back in September of 2011. And what she did was she asked the states and state departments of health to work together to implement this. Many states handled this as a legislative mandate. For instance, the state of Missouri did. We helped provide training for birth facilities and also the follow-up for children who had positive screens. In the state of Kansas, we did not have a legislative mandate that was supported by the legislature. So what we did at Children's Mercy is we worked with the Kansas Department of Health and Environment to implement a quality improvement strategy. The Kansas Department of Health and Environment task force went out to birth facilities and provided education from materials that we actually provided to them. And over the course of 2 years, the state of Kansas went from 30% of the birth facilities screening to 100%, and a total number of babies, which was about 75% of the newborns being screened to 100%. So even without a legislative mandate in the state of Kansas, we were able to get babies screened using the Quality Improvement Initiative.
Now, when is the screening actually done? Is this right as they are being released, or 12 hours before? What's the
time?
protocol?
Yeah, the timing of the screening is very important because the oximetry assessment in the first few hours after life during a transitional period can be sometimes misinterpreted or inaccurate. So the screen is really designed for healthy newborns who are at least 24 hours of age prior to, and of course prior to their discharge. Children who have signs of congenital heart disease before that time, typically because of symptoms or different issues, breathing problems, oxygenation problems, those children are identified quickly and often come to our attention. But as I mentioned, about 25% of babies with very significant congenital heart disease don't actually have those symptoms in the first few days of life, and that's why the oximetry assessment at 24 to 48 hours of age is really critical.
And in that time period, in a healthy infant, how sensitive is pulse ox as a screening tool?
Pulse oximetry is actually quite sensitive. With regard to detecting those critical defects, it's actually got a very good record. There was a concern prior to initiation of pulse oximetry that there would be a lot of false positive tests. That has actually turned out to not be the case. There are some babies who are screened who have an abnormal pulse oximetry screen who end up not having congenital heart disease. However, the screen does uncover other particular problems such as lung disease, sometimes infection. So these are also important clinical problems that are detected by oximetry, even though they're not necessarily congenital heart disease.
All right, and so now that we've laid out the background here and we've talked a little bit about the screening tool itself, in your opinion, has pulse oximetry screening made a difference?
Well, I think we know in many of the states that it actually absolutely has made a difference. One of the concerns that I have about oximetry assessment as we do it now in the U.S., and this is getting better fortunately, is fortunately almost all babies in the U.S. now are being screened with oximetry prior to discharge. What we don't have a standard protocol for yet is reporting. Several states have implemented reporting of their data, and actually states such as New Jersey actually report this publicly, so we can have a very clear view of the number of babies who are having positive screens, and also those positive screens in terms of the impact on saving children with congenital heart disease. In the state of Kansas, we actually do have a field in the electronic birth record and registry for oximetry screening. And so that, I think, has the ability to let us know for sure the number of babies who are coming to detection with this technique. In the state of Missouri, we need to work on better reporting, standardized reporting on a patient level so that we can understand the impact. But just as a clinician who sees a lot of these babies in the first month of life, one thing I can very definitely tell you is that the number of infants coming to our facility with undiagnosed congenital heart disease or with the effects of having had their heart defect not diagnosed in the newborn hospitalization has decreased dramatically. We just don't see very many of those babies anymore. And it's a real transformation compared to where we were 5 years ago when Secretary Sebelius recommended.
Yeah, and such a simple test too, right? I mean, it's
absolutely
easy, it's non-invasive. It's everything you want in a screening tool, right? It
kind of at this point it's amazing to me that we did not implement it earlier, but there were valid concerns about accuracy. Fortunately, several large population studies really confirmed that this was something that was needed, and I'm proud of the efforts on the Department of the State Departments of Health, both in Missouri and Kansas, to really get this going, and also proud of the work that doctors here at Children's Mercy have done as well.
Well, that's awesome. Dr. Kaine, I want to thank you for the work that you are doing with this, the work you do at Children's Mercy, and also thank you for coming on the show this morning. You're listening to Transformational Pediatrics with Children's Mercy, Kansas City. For more information, you go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Mike Smith. Thanks for listening.